of introducing Dr. Margaret Chan, the Director General of the World Health Organization, who will present this evening's keynote address. I should say that she is listed in your program as Dr. Margaret Chan and in my notes as Dr. Margaret Chan, but I learned over lunch that her full formal name is Dr. Margaret Fung Chan. And so at the Princeton-Fung Global Forum, we have yet another reason to be thrilled that you are with us this afternoon. Dr. Chan is a globally renowned public health official with in-depth expertise in communicable diseases and public health regulation. During her 9-year tenure as director of the Hong Kong Department of Health, she successfully managed the threat posed by the H5N1 avian influenza outbreak in 1997 and the outbreak of severe acute respiratory syndrome, commonly known as SARS, in 2003. Dr. Chan received her BA and MD degrees from the University of Western Ontario, Canada. She did postgraduate training in public health at the Singapore National University, where she obtained an MS degree. From 1978 until she became its director, Dr. Chan rose through the ranks of Hong Kong's Department of Health. As director, she introduced new initiatives to improve communicable disease surveillance and response, enhanced training for public health professionals, and establish better local and international collaboration. Her firsthand experience led to her appointment in 2005 as the World Health Organization's Assistant Director General for Communicable Diseases, as well as the representative of the Director General for Pandemic Influenza. The following year, she was elected to her current position of Director General of the World Health Organization. Dr. Chan has received numerous awards for her public health work, including the Order of the British Empire. She exercised pivotal leadership in the response to 2 major health crises, and we are very fortunate that she could participate in this conference. Please join me in welcoming Dr. Margaret Chan.
Thank you, Chris, for that generous introduction. Friends, colleagues, when someone introduces you and tells the audience about your CV, that tells you how old I am. So, Honorable Mr. President, faculty and alumni of Princeton University, distinguished speakers and panelists, representatives of the UN and humanitarian agencies, noted journalists, ladies and gentlemen. I'm honored, truly honored to speak to this very distinguished audience and thank Princeton University and, of course, the generosity of William, who's with us today, William Fung to be exact. For those of you who don't know, Fung is a big family. And a very rich one, too, for making this event possible. Before I start, I wish to commend the brave men and women from the African continent and from afar, from many of your countries, to work together to tackle the most severe and the longest Ebola outbreak. I've been sitting at the back, since this afternoon, and I learned so much from many of the panelists' first-hand experience in dealing with Ebola in the countries over the last 2 years. Ladies and gentlemen, tonight, you are looking at the experiences during the Ebola outbreak in West Africa to explore shared features with past plagues and also to demonstrate several unique features of modern plagues. Ebola is not a new disease. The first outbreaks in what is now known as South Sudan and Democratic Republic of Congo date back to 1976. And I'm sure you all know Peter Piot. I'm sure Peter would have told you, his early experience with the Ebola outbreak there. Prior to the current outbreak, Ebola was a rare disease, largely confined to rural areas, isolated by lack of transportation by road, air, or water. Much about the disease was poorly understood. The previous 22 outbreaks that WHO took part in supporting countries to control them, which occur in Ebola's traditional geographical home in Equatorial Africa. And they were controlled using measures like isolation and quarantine that date back to the Middle Ages. We are now into the second year of the outbreak in West Africa, which is by far the largest, longest, and most deadly and most complex Ebola outbreak in history. Much research has been undertaken, and knowledge of the disease, its patterns of transmission, and its clinical features has improved considerably. But much more needs to be done. Particularly, we need to understand more about viral persistence and also the care for survivors. And I heard some of the comments during one of the panels. Can't agree with you more. What WHO and all other responders failed to grasp quickly enough at the beginning was the potential of Ebola to behave very differently in West Africa than it had in Equatorial Africa. In terms of lessons for future outbreaks, one overarching conclusion is this: outbreaks of new and emerging diseases cannot be reliably predicted, but large, severe, and sustained outbreaks can be prevented. They can be prevented through adequate vigilance, preparedness, and quick detection and response. The watchword is this: be prepared for the unexpected. Constant mutation and adaptation are the survival mechanisms of the microbial world. They are always, we should, for those of us working with, crisis, there will always be surprises. This was Ebola's first appearance in West Africa. The disease was neither expected nor suspected. In Guinea, where the first case occurred in December 2013, the virus circulated undetected off every radar screen for 3 months. The earliest cases in Liberia and Sierra Leone were likewise missed. This late detection gave the virus a momentous head start, which further accelerated when the disease reached capital cities. National and international responders did not begin to catch up until October of last year. As studies now show, late detection and delayed intervention contributed to the outbreak's size. Friends, colleagues, ladies and gentlemen, for vigilance, preparedness, and early response, the context of modern plagues is extremely important, especially in a century characterized by striking inequalities in wealth and fundamental state capacities. This session is looking at the contribution of advances in information and communications technology. That technology played a decisive role in ending the 2003 outbreak of SARS, the first severe new disease of the 21st century. SARS was very much a modern plague. It revolutionized our understanding of the power of real-time communications during an outbreak. One set of statistics illustrates the power very well. In mid-March 2003, let me cast your mind back. WHO used the internet to alert the world to a deadly new disease of unknown cause that was spreading very quickly in sophisticated urban hospitals. I know this very well because I was in the eye of the storm. End of February 2003, a famous professor came to Hong Kong from mainland China and began to spread the disease. I was at that time the Director of Health in the Hong Kong Department of Health. And, following the international health regulations requirement, I reported the cases, the unusual findings to WHO. And at that time, my dear friend, Dr. David Heyman, was working in Geneva. And of course, that message was widely reported and shared with the countries of the world and again amplified, by the global media. On that, countries of the world were alerted. The March alert provided a very clear line of demarcation between the earliest outbreaks in China, Hong Kong, Hanoi, Singapore, and Toronto, all of which were severe, and the additional 26 countries and areas where cases were imported by international air travelers. Areas with outbreaks prior to the March alert accounted for 98% of the global total number of cases and 79% of total deaths. The additional sites, characterized by high levels of vigilance and preparedness, they were able to prevent further transmission or limit it to just a handful of cases. WHO declared the outbreak over less than 4 months after the alert was issued. The Ebola outbreak in West Africa evolved within a very different context. Whereas SARS was largely a disease of sophisticated urban settings, Ebola took its heaviest toll on 3 of the poorest and least prepared countries on Earth. All 3 were recovering from years of civil war and unrest that left health services and infrastructures severely damaged or destroyed. Deep poverty, a disrupted political history, and centuries-old cultural beliefs and traditions created immense barriers to rapid containment. Poverty meant that there was not enough of anything. Doctors and nurses, isolation wards, hospital beds, laboratories, medical supplies, ambulances, daily provisions for people held in quarantine, or even protective gloves and body bags. Transportation and communication systems were primitive in rural areas and also in some cities. Real-time reporting of suspected cases and lab results was out of the question. Many rural areas could not be reached by any form of communication, not even by mobile phone. Every day, dead symptomatic patients were left in the community waiting for test results or transportation to a treatment center gave the virus multiple opportunities to spread. The political history of conflict and unrest left populations deeply mistrustful of government authorities, their policies and advice, their military, and their public health services. People prefer to seek care from traditional healers under conditions that virtually guarantee explosive spread. Foreign healthcare workers, thanks to these brave men and women who went in to help, but they were even more deeply distrusted, frequently to the point of violent resistance. In some countries, competing political factions used the outbreak to promote their own agendas. In fact, cultural beliefs and practices of the community proved to be one of the most difficult barriers to address. Responders took too long to learn how to break this barrier down. The color of body bag matters. It took the international community weeks and months to realize that black color body bag does not work. It has to be white. In the beginning, many communities refused to believe Ebola was real. Rumors spread that all this Ebola business, in quotations, was just that, a business run by government officials to ensure they get foreign funds to pad their personal fortunes. To counter these and other rumors, health officials communicated the message that Ebola was indeed real. In fact, this was an extremely deadly disease with no vaccine, treatment, or cure. Ladies and gentlemen, that message backfired. If hospitals offer no hope, communities found it logical to care for infected loved ones in their homes. where they could die surrounded by familiar faces. Traditional cultural beliefs also dictated funeral and burial practices that involve washing, cleansing, and caressing of the corpse that remain extremely infectious for several days after death. Even after safe burial teams from the IFRC were organized and made quickly available, secret unsafe burials continue. WHO estimates that up to a quarter of all infections in the 3 countries could be linked to high-risk funeral and burial practices. As we learn, communities must be helped to understand the importance of control measures on their own terms. Simply telling them to do this or don't do that does not work. Listen to the people. This is one important lesson we all learn. When communities saw for themselves that hiding patients in homes could lead to the death of entire households, they found their own way to separate the healthy from the infected. They found their own way to identify and quarantine close contacts and keep symptomatic travelers from entering the village. These changes in community behaviors help bring some of the earliest hotspots under control. Some may ask the question, could digital communication systems and internet networks have been used to solve some of these problems and bring about changes earlier? I have some doubts. Given the realities on the ground during this crisis, how can communications technologies help if the messages are not trusted? Or the content of the messages is inappropriate? As we learned, when technical interventions go against culture, culture will always win. In recent years, several systems of digital disease detection have been developed, also in collaboration with WHO. These systems use dedicated software applications, programmed to search open websites, news wires, discussion groups, and blogs for words and phrases in 9 languages that signal a possible outbreak or other health emergency. In many cases, this electronic gathering of disease intelligence operates as an effective real-time warning system. In West Africa, the effectiveness of these systems is blunted. It is blunted by 2 very clear reasons. First, these countries simply do not have a modern telecommunication system. Health-related data that might be picked up by digital systems for disease detection are sparse. This is a reality in poor countries worldwide. Let me tell you one statistics. Some 85 countries, representing 60% of the world's population, do not have reliable systems for collecting, recording, and analyzing even the most basic health data. They do not register births and deaths, and they do not investigate or record causes of death. Second, most poor countries in tropical areas have a heavy burden of other infectious diseases like malaria, Lassa fever, typhoid fever, yellow fever, cholera, and dengue that have non-specific early symptoms similar to Ebola. In the midst of so much background noise, how can surveillance systems, which are almost universally weak, pick up an unusual disease event? Elsewhere, experiences in countries with more robust IT systems in place show some positive results and some negative consequences. In July 2014, an air traveler from Liberia brought Ebola to Lagos, Nigeria, one of the most densely populated cities in sub-Saharan Africa. Lagos has large numbers of people crowded together in slums with little sanitation and vast daily population movements in and out of the city. Under these circumstances, many predicted a catastrophic urban outbreak. That never happened. Nigeria was quick. Nigerian health authorities caught the first case quickly and responded forcefully with supports from international partners, including MSF, US CDC, and WHO, as well as the private sector. State-of-the-art technology developed for the country's polio eradication program was immediately repurposed to support the search for contacts of the first Ebola patient, the tracing of chains of transmission, and the real-time reporting of results. Nigeria had excellent laboratory support and good isolation and quarantine facilities. Of course, this is by comparison. I mean, we cannot compare the system's capability and also capacity in Nigeria with that of, OECD countries. But compared to the 3 Ebola, the hardest hit countries, they have good capacities. And remarkably, the country was able to hold the number of Ebola cases to just 20. Equally remarkable, investigators, many of them were, from WHO and working with partners, we could link every one of these cases to the chain of transmission that began with the Liberian air traveler. In wealthy countries around the world, information technology, including social media, allow fear to spread faster than the virus. As I was sitting in the back, I hear some of your comments and your personal experience about the role of fear that play in this overall scheme of things. This fear could not be contained by the well-documented facts that Ebola is not airborne and spreads only under conditions involving very close contact with infected bodily fluids. In reality, the risk of onward transmission following an imported case is very low in countries with high standards of living and well-developed health systems. Despite these facts, numerous airlines cancel flights to all of West Africa, and some countries refuse to issue visas for travelers from affected countries. The cancellation of flights make it extremely difficult to move badly needed personnel and supplies into the 3 countries. Joanne from MSF and I were on constant dialogue on how to overcome this challenge. Apart from impeding the speed of the international response, these measures isolated and stigmatized the 3 countries ever further. So, ladies and gentlemen, let me leave these thoughts with you. In my view, the first priority must be to get well-functioning health systems in place, especially in fragile and vulnerable countries. It is the duty and responsibility of the countries to take care of their people. Remember the people. Unfortunately, this is not the case. In far too many countries, they do not have a people-centered, well-functioning system, including surveillance and laboratory services, but also offers comprehensive care close to people's home. Surveillance function is not just to detect outbreaks early. Of course, that is important. But surveillance is also important to detect other problems like malaria, like HIV, chronic non-communicable diseases, because with all these conditions, early prevention and treatment are best, and the costs are much lower, and the suffering of the people are much less. So, ladies and gentlemen, going forward, WHO, with the support of many countries, is advocating very strongly that every country should build a well-functioning, people-centered, and inclusive health systems, without which it's very difficult to build trust between the people and the government. And without a good universally covering everyone, nobody should be left behind because they are women, because they are poor. We advocate universal health coverage to make sure that everyone's needs is addressed. Universal health coverage, we believe, is the kind of system that will build resilience. Resilience to protect people, to protect the population from sudden shocks, whether these shocks are coming from a changing climate, from a natural disaster, or a runaway virus. Thank you. I was asked whether I'd like to do some Q&A. Pleasure. No question. Oh dear. Thank you.
Thank you. My name is João Bill. I teach anthropology at Princeton University. And we have followed the Ebola outbreak from various perspectives on campus with students. And one question that students generally come up with is, what happened at the internal level of the WHO that led also to a late response? We heard from you about the late response from the governments. What is it in the very financial structuring, decision-making structuring, leadership structure of the WHO that somehow helped to make sure that there was no early action? Yeah.
I think I can look at it from two perspectives. Timely information is extremely important. If there is any roadblock for the movement of information up to the decision-making leaders is important. So when I say leaders, it means leaders at all levels. It can be at the country, regional, or head office level. Unimpeded movement of information to facilitate timely decision-making is extremely important. Now, of course, when you look at Ebola, it's a disease with 40-year history. And if you believe in numbers, I also heard the importance of numbers and counting this morning. When you look at the epidemic curve in May, at that period, early responders, including MSF, US CDC, and WHO, we thought the Ebola outbreak was under control, without realizing, because of the mistrust of the community, both to the government and to the responders. And of course, I mentioned about the messages that backfire. People do not bring their loved ones to healthcare centers, and they keep them at home, and it is like a fire spreading, like a pit fire, below the surface. So it is very difficult to manage what you don't see, and when you manage what you don't know. And if you look at the epidemic curve, the diseases were really coming down, but it was not. It was spreading below the radar screen. So again, accurate, timely information is extremely important, knowing the real size of the problem in order to manage. As Gabriel, I still remember, Gabriel from MSF Ireland, where are you? Here. Well done. Gabriel make it, very fairly and squarely. No organization, no government can say that they have done well in Ebola. Collectively, there are so many lessons for all of us to learn. Yes.
Emmanuel Darcourt from the International Rescue Committee. My question is regarding the call that you made at the end of your talk about sort of dedicating ourselves to building health systems. Liberia had substantial support, both technically and financially, for the better part of a decade prior to Ebola, and wasn't obviously the health system was found wanting at a time of need. What do you think needs to happen, and do you think it's feasible to think that with the same leadership we will get a good health system when with the ingredients we didn't get one?
You ask a very difficult question, Emmanuel, but a very relevant one. Not just you, and in fact, in my conversation with many countries who have been very generous in providing ODA support to so many low-income countries to help them to build capacities. They keep asking the question, what happened to our investment in the last 10 years, 20 years? My answer to them is, of course, there are many reasons, but at least since year 2000 with the MDGs, it was good in unleashing, ingenuity, partnerships, a lot of funding, but the tendency to go in a disease-specific to deal with single disease, commodities, those are important, but without addressing the horizontal elements of health systems, meaning health institution capacity, information system, infrastructure, we are not going to get there. So the lessons for all of us to learn going forward is we need commodities, we need all these disease-specific, but they got to be integrated in such a way based on the health needs of the community and the people. So Emmanuel, yes, we all have to learn, including the donor countries, the ODA supporters. I mean, many of them, were very good. UK, 0.7% of their GDP, and many other countries, Nordic countries. But going forward, we need institutional capacity, we need transparency, we need accountability to hold all people to account. Without accountability, it doesn't work. Why do we? Well, I better be careful. The money should be put to good use to serve people, not to private bank accounts. Sorry, the light is so bright, I just didn't see you. But anyways.
Ross Tamming from Concern Worldwide. Just a couple of things. One is, do you think that this crisis will lead to countries making better donations to WHO, funding it better? And maybe you could talk about some of the very specific lessons you feel WHO has learned from this. And then the third point is, you may have heard in one of the panels, I think it was Gabriel actually, was calling for a specific international health response force. Is that something you support, or do you think there's enough existing mechanisms that could just be strengthened? Thank you.
I was in the audience when I was listening to that panel's conversation. Let me answer your first question and then I come to that one. First one is, this is Ebola crisis, is a second wake-up call, me as a Director General, informing all my member states. I have 194 countries in WHO, 194 bosses. In 2011, Professor Harvey Feinberg, the president of the IOM, helped WHO to do a review of the performance of WHO in the pandemic H1N1 outbreak in 2009 and 2010. At that time, the conclusion was the world is ill-prepared for a severe and sustained outbreak. Ebola is both, okay? At that time, unfortunately, the recommendations were not supported because the recommendations came at the heel of the most severe financial crisis of the world in 2008 and 2009. So those recommendations were not supported, and countries did not provide the funding and the political support for WHO to move things forward. So that's why I'm saying to my member states, this is a second wake-up call. The world is ill-prepared. You cannot not address these gaps in the international system going forward. So I agree with what Gabriel says, because it is not conducive to build a system in the midst of a crisis. It doesn't work. So we do need to look at whether or not the countries themselves have the basic capacity to deal with outbreak first and foremost. If not, what about other countries in the neighborhood, in the region, or at the global level that can provide the surge capacity to help them to mount a very robust response to contain outbreak. So for your information, I've been advising, of course, this is guided by the member states' decision to set up a global workforce, emergency workforce, but WHO is going to work with countries first and foremost to support them to build their own rapid response team and then build a regional and international response. But all these have to be done before the crisis. That means advanced discussion, advanced arrangement, including simulation exercise, and then rules of engagement, and what are the triggers to deploy people, where to, and who's going to coordinate. All these are part and parcel of the WHO reform going forward in the next 12 months. And you will see from the advisory group that is chaired by Dr. David Nabarro, and involving experts from both Outbreaks as well as experts from the humanitarian sector to give me advice on how to formulate a unified program within WHO to provide support in the event of another big crisis. I just hope that we don't see that, but we never know. The next crisis can be 10 years away, 5 years, or 2 weeks around the corner. This morning, I also heard a very important comment from one colleague from Africa about the importance of zoonosis. The importance of zoonosis. 70% of the new diseases we've been seeing in the last 30 to 40 years, 70% of them are coming from the animal kingdom. So the human-animal interface is such that we need to be careful. And part of that, people some scientists is telling us the deforestation in sub-Saharan Africa, bringing ever closer the human population with the bats population that are carrying the virus is something we really need to rethink. As we are speaking, more than 20 countries in sub-Saharan Africa is vulnerable to Ebola outbreak. So all the lessons we have learned so far, including the development in vaccines, medicines, diagnostic, we hope that it will, at least we have better tools to deal with the next outbreak.
Please join me in thanking Dr. Margaret.
Thank you.
Dr. Chan, we know how busy your schedule is, and we are absolutely delighted that you were willing to take time to be with us for this conference. You've given us a remarkable conclusion to a very illuminating day of conversations, and we're grateful to you for that. You've also provided us with a bridge to tomorrow's conversations, and I hope everybody will be joining us again tomorrow as we delve into a set of policy issues with panels on politics and aid, including one with Angus Deaton, this year's Nobel laureate in economics. We will wrap up with a panel, a commission about the future and what is likely to happen or what can be done. And we will, for those of you who have been asking, where are the anthropologists? We will have anthropologists on our panel tomorrow. So I look forward to seeing all of you there. We have a reception that will now be taking place in the lobby outside this room. I hope you will be able to stay for that. And please let me ask you to conclude our afternoon by once again thanking Dr. Margaret Chan for her remarks.